So when you step into the world of upper limb tendon transfers, you were really no longer just a mechanic swapping out broken parts.
Right. You become a biological engineer.
Exactly. Working with a very strict biomechanical budget. You only have so many working muscles to spend, you know?
Yeah, and today we're looking at what happens when you have to deliberately disconnect a perfectly good muscle, reroute it across the arm, and ask the patient's brain to learn an entirely new physiological language.
It's fascinating. And we're going to break down the exact rules of that budget today. Plus, by the end of this deep dive, we'll solve the ultimate exam mystery, which is the ulnar paradox.
Ah, yes, where a seemingly devastating high nerve injury actually leaves the hand looking completely normal compared to a low one.
It is the ultimate test of spatial and functional anatomy.
Oh, absolutely. I mean, the board examiners, they don't just want to see if you memorized a list of textbook procedures. They really want to know if you actually understand the underlying forces pulling on those joints.
Right. So if you are listening to this, you're likely a resident preparing for your plastic surgery board exams, like the FRCS.
Yeah, and as two plastic surgeons who have sat exactly where you are sitting right now, our mission is to rigorously review the principles and applications of tendon transfers for nerve palsies.
No fluff, just the biomechanical why and how you need to survive the Viva.
Exactly.
But before we spend our first piece of biomechanical currency, hit follow on whatever platform you're using right now to listen.
Yeah, and if this revision session helps your exam prep, please leave us a rating.
And to really take your prep to the next level, get the premium subscription to access the exclusive journal club and the clinical cases, it's totally worth it.
I highly recommend it.
All right, let's establish the rules of the bank. Before we look at any specific nerve deficit, what are the rigid prerequisites for a transfer? Because, I mean, if you don't understand the foundation, the whole surgical plan just crumbles.
Yeah, it really does. So you have to evaluate three distinct elements. You've got the patient, the recipient site, and the donor muscle.
Okay, starting with the patient.
Right. So they must be highly motivated and cognitively able to participate in specialized physiotherapy.
Because you're asking their motor cortex to basically rewire itself.
Precisely. A technically flawless surgery will yield a completely useless hand if the patient cannot do the mental work of rehabilitation.
That makes sense.
Yeah.
Then we evaluate the real estate, right? The recipient site.
Yeah, the recipient site is non-negotiable territory. You need a stable skeletal framework, for one.
Right.
And you need full passive range of joint motion. I mean, you cannot transfer a tendon to move a stiff, contracted joint. The muscle simply won't have the force to overcome it.
No, of course not.
You also need supple, soft tissue coverage without any, active tethering scars. But perhaps the most critical and honestly often overlooked factor is sensation.
Yeah, let's hover on sensation for a second. Because I remember in training seeing a technically beautiful opponent's plasty just fail functionally because the patient's median nerve territory was completely numb.
Yep, it happens.
So why is that sensory feedback an absolute deal breaker for these complex transfers?
Well, because proprioception is basically the invisible hand guiding our fine motor skills.
Right.
If a patient has profound sensory loss in their thumb and index finger, they cannot feel what they are pinching. The brain relies on that tactile feedback to gauge how hard to press.
Oh, wow. So even if the mechanics work.
Exactly. If you restore the physical ability to oppose the thumb, but the brain receives no data from the fingertips, the patient will simply bypass that thumb. They'll use a different, clumsier grip that they can actually feel.
So you've performed a surgery the patient will never functionally use.
Exactly. It's a waste.
Okay, so the patient is fully on board, the joints are supple, the tissue is clean, and they have protective sensation. Now we open the vault and pick our donor muscle.
Yes, and this is where we rely on the classic apolycell mnemonic, APOSLE.
Classic. Let's break down these donor prerequisites, starting with A for amplitude.
Right, so amplitude is the actual physical excursion of the muscle. It's how far the muscle belly can contract and actually pull the tendon.
Okay.
You must match the excursion of the donor to the natural excursion of the tendon it's replacing. And the fundamental rule of thumb here is 3, 5, and 7 centimeters.
3, 5, 7. Got it.
Right. Wrist flexors and extensors require about 3 centimeters of amplitude. Finger extensors need 5 centimeters. And finger flexors require a massive 7 centimeters of excursion to pull the fingers into a tight fist.
Okay, here's a scenario that always trips people up in the anatomy lab.
Let's hear it.
You have a donor muscle, say a wrist flexor, that only gives you 3 centimeters of amplitude, but you need it to drive finger extensors, which demand 5. How do you physically manufacture that missing length in the operating room?
Yeah, that's a great question. So, surgically, you can mobilize the muscle belly by freeing up all the fascial tethers proximally.
Right.
But, that really only gives you a fraction of what you need. The real functional gain comes from leveraging the tenodesis effect.
Ah, the tenodesis effect.
Exactly. If you route your transfer across a mobile wrist joint, the patient can actively flex their wrist to passively increase the tension on those extensor tendons.
I see.
That dynamic wrist movement adds roughly 2 to 3 centimeters of effective amplitude to your transfer.
Which explains perfectly why performing a wrist fusion on a tendon transfer patient is just a catastrophic biomechanical error.
Oh, absolutely. You fuse the wrist, you permanently lock out your tenodesis effect, and you instantly rob your transfer of that crucial extra amplitude.
And it just creates a cascading functional failure.
Exactly. The fingers simply won't open fully.
Wow. Okay, moving on to P in apostle, power and control.
Right. So the standard biological tax of a tendon transfer is that the muscle will lose at least one MRC motor grade once you reroute it.
Meaning we are essentially forced to harvest a grade 5 fully normal muscle.
Yeah, a grade 5 is the gold standard. A grade 4 is acceptable, though it will drop to a 3, meaning it can only move the joint against gravity, not against actual resistance.
Which isn't ideal.
No, and a muscle starting at grade 3 is entirely useless as a donor. Furthermore, muscles that have been previously denervated and then reinnervated, they lack the robust cortical control required to learn a new function.
That actually brings up the brachioradialis.
Yeah.
I mean, it is a massive, bulky grade 5 powerhouse.
That is.
But residents quickly learn it's not the easiest currency to spend. Why does the brachioradialis have such a notorious reputation?
Because it is famously known as the naughty boy of the forearm.
The naughty boy. I love that.
Yeah. Yes, it has tremendous power, but it is an elbow flexor by nature. Its cortical mapping is deeply, deeply entrenched.
Okay.
So when you transfer it down to the hand to, say, flex the thumb, it struggles to adapt. The patient will try to pinch their thumb and their elbow will just reflexively pop into flexion.
Oh, man. That sounds frustrating.
It is. It requires intensive, really frustrating cortical retraining for the patient to learn to fire it independently.
Got it. Let's move to O, which stands for one tendon, one function.
Very simple rule. Never split a single tendon's vector to perform two different jobs. You cannot ask one transferred muscle belly to simultaneously extend the wrist and flex the fingers.
Right, because the forces dissipate, and it will accomplish neither task effectively.
Exactly.
Following that is S for synergistic action. This is all about respecting the brain's existing wiring, right?
Yeah, exactly. Think about the natural, unconscious movements of your own hand. When you make a tight fist, your wrist naturally extends to optimize the flexor tension.
Right.
And when you open your fingers wide, your wrist naturally drops into flexion. Because the brain already fires those muscle groups together, transferring a wrist flexor to become a finger extensor is highly synergistic.
The patient doesn't even have to think about it.
Exactly. The brain's pre-existing software runs the new hardware perfectly, and rehabilitation is dramatically faster.
I love that analogy. Okay, next is L for line of pull.
Tendon transfers are most efficient when they pull in a straight line. Every time you deviate a tendon around a fascial sling or a biological pulley, you introduce friction, you alter the vector, and you significantly weaken the transfer's power.
So keep the routing as direct as anatomically possible.
You got it.
And finally, E for expendability. This is really the absolute golden rule of our biomechanical budget.
It is. You must never create a new functional deficit just to mask an old one. If a patient has a nerve palsy, you cannot harvest a muscle that the hand is currently relying on for critical stability.
Right. You only take what the hand can afford to lose.
Exactly.
So when we actually scrub in to execute these principles, there are 3 rapid-fire surgical rules you need to articulate for the boards.
Yes.
Rule 1, operate in reverse. Always prepare your recipient site and create your routing tunnels first before you ever detach the donor muscle.
Right.
You don't want a harvested muscle just sitting around drying out while you dissect the hand.
Right.
Rule 2, avoid interference. Ensure your newly routed tendon isn't compressing any adjacent neurovascular bundles. And Rule 3, set the tension correctly using the tenodesis test on the table. You weave the tendons, move the wrist passively, and watch the hand cascade into position to ensure the tension is perfect before you close.
Yeah, and if you clearly communicate those APOS-L app principles and those specific surgical steps, the examiner knows you are a safe surgeon.
Right. So let's take that safety and make our first investment. Let's spend some of this biomechanical currency on the most classic board scenario, which is the radial nerve palsy.
Ah, the characteristic drop wrist.
Exactly. Break down the specific motor deficits we have to reconstruct here.
So a high radial nerve lesion removes three critical functions. You lose active wrist extension, you lose finger extension at the metacarpophalangeal or MCP joints, and you lose radial abduction and extension of the thumb.
So the hand essentially just hangs limp and cannot open to grasp objects.
Exactly.
We need to restore all three. And to do that, we look to the classic textbook transfer. Let's walk through the anatomical routing.
Okay, so the standard protocol starts by taking the pronator teres, the PT, in the forearm and transferring it to the extensor carpi radialis brevis, the ECRB.
Right, to restore that strong central wrist extension.
Exactly.
But wait, I recall staring at this in the anatomy lab and being totally confused. The pronator teres inserts halfway up the radius. It physically looks too short to reach the ECRB tendon down near the wrist.
It is.
So how do you actually bridge that physical gap in a real surgical scenario?
That is exactly the nuance an examiner is waiting for you to mention. You cannot just divide the tendon at its insertion. To get the necessary length, you must meticulously harvest the pronator teres along with a 2 to 3 centimeter strip of radial periosteum.
Ah, the periosteum.
Yes, that extra periosteal tail provides the physical length you need to execute a strong weave into the ECRB.
Okay, so that handles the wrist. Now to get the fingers and thumb open, we need to borrow from the flexor side.
Right. We take the flexor carpi ulnaris, the FCU, and route it around the ulnar border of the forearm, weaving it into the extensor digitorum communis, the EDC, to restore finger extension.
Got it.
Then we take the palmaris longus, the PL, and reroute it to the extensor pollicis longus, the EPL, to pull the thumb out of the palm.
Now, that is the classic approach.
Yeah.
But there is a highly testable alternative, right? The superficialis or Boy's transfer.
Yes.
And it completely changes the donor profile.
It does. The Boy's transfer is an elegant solution that preserves the FCU, which is a massive wrist stabilizer. You still use the pronator teres for the wrist, but you attach it to both the ECRL and ECRB.
Okay.
And for the thumb, you use the flexor carpi radialis, the FCR, weaving it into the abductor pollicis longus and extensor pollicis brevis.
The finger reconstruction in the Boy's transfer is where the anatomy gets incredibly 3D.
Oh, yeah.
Paint a visual picture of how we use a flexor digitorum superficialis, the FDS, here.
Okay, so you harvest the FDS tendons of the middle and ring fingers from the volar side of the forearm. But instead of routing them subcutaneously around the borders of the arm, you surgically create a window directly through the interosseous membrane.
That thick fascia connecting the radius and ulna.
Exactly. You tunnel the middle finger FDS straight through that window to the dorsal side, attaching it to the EDC for general finger extension. And then you tunnel the ring finger FDS through the same window to drive the extensor indicis proprius and the EPL for independent index and thumb extension.
Tunneling straight through the interosseous membrane, I mean, that perfectly satisfies our line of pull principle. It creates a remarkably direct, straight vector from the volar forearm to the dorsal hand, minimizing all that friction.
It really is a biomechanical masterpiece when it's executed correctly.
So we've solved the drop wrist, we've given the patient extension, but a hand that can only open is useless without the ability to grasp and pinch. That brings us to the complex, multiplanar world of the median nerve, where our biomechanical budget gets severely stretched. We have to restore opposition.
Yes, we do.
First, anatomically, how are we defining a high versus a low median nerve lesion?
The crucial anatomical dividing line here is the origin of the anterior interosseous nerve, the AI, up in the proximal forearm. If the nerve is severed distal to the AIM, it is a low palsy.
Okay.
If the injury is proximal to the AIN, it is a high palsy, and the deficits are far more profound.
Let's focus on the low lesions first. The primary devastating deficit here is the loss of thumb opposition, specifically because the abductor pollicis brevis, the APB, is paralyzed.
Right, so the thumb just lies flat alongside the index finger.
We need to perform an opponent's plasty. Let's walk through the biomechanics of the classic options, because the pulleys dictate the function here. First, let's talk about the Royal-Thompson transfer.
Okay, the Royal-Thompson uses the FDS of the ring finger as the donor. You divide it distally, but the biomechanical magic is really the pulley. You route the tendon across the palm, utilizing the natural anatomical angle between the ulnar border of the palmar ponderosus and the distal edge of the transverse carpal ligament.
I see.
By hooking the tendon around that fascial edge, you redirect its force toward the pisiform before attaching it to the APB insertion. This pulls the thumb across the palm into opposition.
Interesting. Now compare that to the Bonal technique, which also uses the FDS of the ring finger.
Yeah, the Bonal technique actively constructs a new pulley. You dissect a distally based strip of the flexor carpi ulnaris tendon right at the pisiform bone.
Okay, you make a strip.
You loop that strip to create a physical ring, pass the FDS tendon through it, and route it subcutaneously across the palm, passing it dorsal to the thumb MCP joint to secure it to the proximal phalanx. The pull from the pisiform creates an excellent vector for true opposition.
Another option is the extensor indices transfer, where you take the extensor indices from the dorsal hand, route it around the ulnar aspect of the wrist, proximal to the extensor retinaculum, and suture it into the APB.
Yeah, that's a good one too.
But I want to scrutinize the Kametz transfer. It uses the palmaris longus, elongated with a strip of palmar fascia.
Mm.
When you look at the vector, pulling straight down the center of the forearm, does it actually restore the complex 3D rotation of opposition?
You've highlighted the classic exam trap.
I knew it.
Because the palmaris longus pulls directly down the midline of the volar forearm, the Kametz transfer does not restore true dynamic pronation and opposition of the thumb.
So what does it do?
It simply restores palmar abduction. It's just pulling the thumb straight up away from the palm. It is an excellent operation for older patients with severe, long-standing carpal tunnel syndrome, where you are already opening the fascia anyway, but functionally do not call it a true opponent's plasty in your Viva.
A vital distinction.
Yeah.
Good to know. Finally, for low lesions, there's the Huber transfer, which radically alters the anatomy of the hypothenar eminence.
The Huber is visually striking. You take the abductor digiti minimi, the ADM, which normally pulls the little finger outward. You detach its origin and insertion, but you meticulously preserve its proximal neurovascular bundle.
Essential.
Then you literally flip the entire muscle belly 180 degrees on its long axis. The classic analogy is like turning the page of a book.
Turning the page of a book.
Yeah, you transpose it across the palm through a subcutaneous tunnel and suture it to the APB insertion. Not only does it restore function, but it uniquely restores the physical muscle bulk to a wasted thenar eminence.
That covers the low lesions. If the injury is high, proximal to the AIN, the budget collapses further. We lose forearm pronation, and critically, we lose flexion of the thumb and index finger because the flexor pollicis longus, the FPL, and the lateral half of the flexor digitorum profundus, the FDP, are gone.
Interestingly, though, the middle finger FDP is usually spared.
Oh, really?
Yeah, there's often a neurological crossover in the forearm where the ulnar nerve supplies both the ring, little, and middle finger FDPs.
So to reconstruct a high median palsy, we still do an opponent's plasty, but we have to add heavy lifters for pinch grip.
Exactly. To restore index finger flexion, a common choice is transferring the extensor carpi radialis longus, the ECRL, to the paralyzed index FDP tendon.
Okay.
To restore thumb flexion, we often use the brachioradialis to drive to FPL. Alternatively, if donor muscles are scarce, you can perform a side-to-side tenodesis.
Meaning literally suturing the paralyzed index FDP tendon to the functioning middle and ring FDP tendons.
Exactly. When the ulnar nerve fires the intact fingers, they drag the index finger down with them. It provides synchronous movement, though it lacks independent power.
We've covered the simple transaction of the radial nerve and the complex investment of the median nerve. Now, we arrive at the market crash of our biomechanical budget.
The ulnar nerve palsy.
Yes. This introduces the most notorious physiological trap in all of plastic surgery, the ulnar claw and its paradox. First, establish the baseline deficits. What muscles are we losing?
You lose thumb adduction. You lose the dorsal interossae, which handle finger abduction, spreading the fingers apart. You lose the palmar interosseae, which handle finger adduction, bringing them together. And crucially, you lose the lumbricals to the ring and little fingers.
And the loss of those intrinsic muscles is what triggers the claw deformity. Let's map out the forces creating that claw. Imagine the hand as a tent.
Okay, I like that.
The intrinsic muscles, the interossae and lumbricals, are the guy lines, keeping the structure perfectly balanced. Their normal anatomical job is to flex the MCP joints, the big knuckles, and extend the interphalangeal, or IP, joints. When those intrinsic guy lines are cut by an ulnar nerve injury, the massive extrinsic muscles take over completely.
Right, the balance is destroyed. The powerful long extensors on the back of the hand pull the MCP joints into severe, unopposed hyperextension. Because the FCP joints are cranked backward, the extensor tendons physically cannot reach far enough down the finger to extend the tips.
That makes sense.
Simultaneously, the powerful long flexors on the volar side pull the IP joints into tight, unopposed flexion. The result is a hand with knuckles bent entirely backward and fingertips curled tightly into the palm.
Which brings us to the ulnar paradox. I recall staring at textbook photos of this and being completely backwards on the logic.
It gets everyone.
In almost every other scenario, a higher, more proximal nerve injury creates more devastating clinical picture. But the ulnar paradox states that a low nerve injury at the wrist creates a much uglier, more severe claw hand than an injury up at the elbow. Break down the biomechanics of why that happens.
It feels completely counterintuitive until you look at the flexor tendons. In a low ulnar nerve lesion at the wrist, the intrinsic muscles in the hand are paralyzed, initiating the claw. However, the nerve supply to the long flexors in the forearm, specifically the FDP to the ring, and little fingers branches off high up near the elbow.
Oh, I see.
So in a low lesion, those powerful FDP muscles are perfectly intact. They are firing at full strength, violently pulling the fingertips into deep, severe flexion, creating a terrifying-looking claw.
And a high lesion.
In a high lesion at the elbow, the nerve is severed before it can innervate those long forearm flexors. The FDP muscles to the ring and little fingers are completely paralyzed.
Wait, so the flexors aren't pulling anymore?
Exactly. So while the intrinsic muscles in the hand are still dead and the knuckles still hyperextend, you no longer have that massive flexor force curling the fingertips into the palm. The fingers just hang loosely. A worse, more proximal nerve injury paradoxically gives you a milder, less deformed-looking hand.
That is the definitive explanation of the ulnar paradox. So how do we use our remaining tendon transfers to fix this collapsed tent? Let's start with the thumb, which has lost adduction, making key pinch impossible.
To restore thumb adduction, you can use the ECRB or the brachioradialis, extend it with a tendon graft, pass it transversely through the third intermetacarpal space, and insert it into the adductor tubercle on the thumb.
Okay.
Alternatively, you can take the FDS from the middle or ring finger, route it across the palm using a fascial pulley, and attach it to the same insertion point. Both vectors pull the thumb tightly against the index finger.
But correcting the claw itself requires an understanding of joint mechanics.
Yeah.
We don't necessarily have to replace the exact intrinsic muscles, right? We just have to block the hyperextension.
Exactly. Biomechanics dictate that if you simply prevent the MCP joints from flipping backward into hyperextension, the long extensor mechanism on the back of the hand will retension itself and successfully extend IP joints. You just have to stop the knuckles from hyperextending.
What is the most reliable technique to create that block?
The workhorse is the Zancali lasso technique. Picture the A1 pulley sitting right there at the base of the finger in the palm. You take the FDS tendon of each clawed finger, divide it, and pull it proximally. You make a small transverse window in the A1 pulley, pass the FDS tendon through it, wrap it completely around the pulley, and suture it tightly back onto itself.
You are essentially creating a biological bumper.
Yeah. By lassoing the A1 pulley, you permanently tether the MCP joint in slight flexion, making it physically impossible for it to hyperextend to a claw.
You turn a joint flexor into an MCP joint stabilizer. It's brilliant. Are there other options?
Historically, there is the Stiles bundle procedure where you split the FDS into slips, route them through the lumbrical canals, and weave them into the lateral bands to mimic the intrinsic muscles. However, it is a highly complex procedure prone to severe adhesions and finger stiffness.
Good to know.
Examiners want to hear that you know it exists, but they also want to hear that you know why we avoid it today. Finally, there is the brand transfer, which takes the ECRL or ECRB, elongates them with plantaris tendon grafts from the leg, tunnels them through the intermetacarpal spaces, and inserts them into the lateral bands. It is a powerful, dynamic reconstruction for severe intrinsic loss.
This has been an intensely dense, high-yield deep dive into surgical mechanics. Let's synthesize the ultimate FRCS survival strategy for tendon transfers. First, you must rigorously respect the apposal principles. If you miscalculate the amplitude, overestimate the power, or ignore the expendability rule, your surgical plan will fail.
Totally fail.
Second, you must precisely match the biomechanical vector to the anatomical deficit, prioritizing synergistic donors to accelerate rehabilitation. And third, Never get caught off guard by the ulnar paradox, remember. A low lesion leaves the long flexors intact, aggressively curling the fingers into a worse claw.
If you can confidently articulate the why behind the vector forces and the routing pathways of these transfers, you will completely dominate this topic in any board scenario.
Before we wrap up, I want to leave you with a final clinical variable to ponder. We have laid out the rigid textbook blueprints. We know the rules of the biomechanical budget. But consider how your entire surgical strategy must pivot if your radial nerve palsy patient is a heavy manual laborer who requires massive crushing grip strength to hold a tool, versus a classical concert pianist whose career depends on hyper-independent fine finger dexterity.
Right.
The physiological mechanics remain identical, but that expendability rule completely shifts based on the human being attached to the hand. Suddenly, you aren't just replacing an engine part, you are redesigning the entire machine for a very specific road.
Recognizing that functional nuance is the critical transition from thinking like a resident to operating like an attending physician.
If this breakdown of tendon transfers clarified the biomechanics for your exam prep, please leave us a rating and make sure to hit that follow button.
Yeah, definitely hit follow.
And remember, if you want to push your knowledge further with our journal club and clinical cases, secure that premium subscription. Finally, we want to hear your thoughts. Drop a comment or a question about today's deep dive directly on the platform you're using. Keep studying hard, and we will catch you on the next one.